All right. Thank you, everybody, for joining in. I don't know if most of the centers have joined in, but I heard at least my medical school DOF has joined in already. So I am Atif. My full name is Atif Zafar, and I am currently just about to finish my fellowship in stroke, and then I'm joining as a faculty in one of the academic programs here in US starting July, inshallah. So the topic that I thought I would discuss today is acute stroke management. And the reason why I wanted to discuss this with our friends in Pakistan and maybe a few in Saudi Arabia was because, as you know, that in the last couple of years, these exciting and new developments have happened where new treatment options have become available for our stroke patients. So that's why I call this as a new era in stroke care. I've got quite a few slides in there, but I'll go through them pretty quickly. The goal will be that by the end of today's session, which will be about 40-minute lecture from my part, followed by questions from you guys. The goal is that I want to summarize where we stand with stroke. We'll just touch base a little bit about TPA, and then we'll talk about all the interventional approaches that have come in and what are the imaging advancements. I'm sure there are a lot of medical students, some of the residents in there, and maybe a few faculty. So the goal actually is at Cleveland Clinic, the advantage is that we get all the new technologies, even the third generations that have now transformed into the fourth generation stents are being used at our clinic. So I would like to touch base a little bit on those stents as well. So let's begin. I want to start with discussing this big picture. I know most of you know a lot of the things that I'll be discussing, but the goal is that everybody gets on board. Everybody knows by the end of today's session what actually stroke care is about and where we are heading towards. So stroke is the leading cause of disability in the world. Luckily in the United States, in the last 8 years, we've brought it down as the 5th cause of death in the country here in US, but unfortunately in the world overall, especially the third world countries, it's still the 3rd cause of death worldwide. And you can imagine, I'm just talking about the cause of death, how many patients, how many people we know have a stroke and end up having disability after that. They can't walk independently. If they were working, they cannot go back to work. So that part is not even included in this morbidity picture here. So billions of dollars are kind of spent and invested on this disease. There are a lot of stroke survivals, counting them in millions, where they end up having a stroke, and then a few years later, or a few days later, or a few weeks later, end up having more strokes, causing more disability. And obviously, eventually, especially keeping in mind that in the third world countries where we mostly have one earner for the whole family, if that earner ends up having a stroke, causing a loss of job, we can imagine how much disability it will cause for the whole family. So in short, it's a big problem. I mean, finding the cure, finding the right treatment for stroke patients is a very, very important task. So let's start our slides now. So the first case I want to present is a pretty usual case. I mean, typically most of our stroke patients are in their 60s or 70s or 80s, but now, in this era, we're seeing more and more patients in relatively early age. So in this case, 42-year-old male comes in to the ER. He's got a history of non-ischemic cardiomyopathy with a low EF, ejection fraction is low. and we know he has heart failure, and he comes into the hospital. He was last seen normal at 8:30 in the morning, and he was found with some symptoms at 10 a.m., so 1 hour and 30 minutes after he was last seen normal. He had some global aphasia and minimal movement on the right side, so his language functions were impaired, and he had pretty significant deficits on the right side. His NIH stroke scale was 18. Most of it deficits on the right side, and again, he was not able to answer questions, and he was not able to read, repeat, or name anything. So a CT scan was done as soon as the patient came to the ER within 30 minutes, and you can see the picture over there on the right-hand side on this slide. There's some artifact, which is something that we normally see in our patients, especially if they have dentures or some eye implants. So this is kind of a routine HCTVC. Overall, it looks fine. The gray-white differentiation here looks okay. This is just one cut of the full CAT scan, but it was read as normal, and IV TPA was started within 35 minutes of doing the CAT scan. So this is one of the usual case scenario, and then we'll keep talking about it as we move further. But as I move on with this slide, what I'll do is I'll start from the very basics, and then we'll go ahead to the more complex aspects of stroke management. So the first thing is recognizing stroke. Even in countries like US or in England or in Sweden, most of the patients present to the ER after 4 or 5 hours at least. So they're already out of the TPA window. That's one of the major challenges. So that's one of the things that the physicians, especially the neurologists and stroke neurologists, focus on starting these awareness projects, making sure that the people, the general public, knows what stroke symptoms are like and how they can present. And that's something that even in our third world countries is a major problem, because most of the patients who present to the hospitals have been having deficits on one side of the body or the other for quite a while. So on this slide, you'll see that the symptoms are mentioned, and then it kind of, as you can see the arrow on the top, points out, is this a stroke or not? Because a lot of times it can be a seizure and post-ictal paralysis that can mimic a stroke-like symptom. They can be confused. They can have their sodium too low that ends up causing some encephalopathy, if not full-fledged seizure. And if they had a history of stroke, it's possible that they got sick, a urine infection, and their old stroke symptoms are manifesting again. But in any case, these are challenging differentials. However, a good history can differentiate a seizure from a stroke. And that's one of the most common things that you need to do before considering a TPA, especially if the patient presents within 3 to 4.5 hours of onset. Now, the other question is, when a patient presents to the ER within 3 or 4.5 hours of onset, you have to ask how bad this acuity is. I mean, because a lot of times it's possible that the patient end up having some numbness or tingling on the right side of the body 12 hours ago, and then it proceeded or it evolved into a full-fledged weakness on the right side. If that's the case, then the last known normal will be obviously 12 hours ago. And that's one of the challenges for TPA patients as well, because a lot of times patients go to bed feeling fine and they wake up in the morning having stroke-like deficits. So in those cases, the last known normal was last night, and then they are not TPA candidates. Similarly, a patient comes in and he was having a headache and some numbness on the lower part of the face on the right side, and then 8 hours later, they end up having a facial droop, some problems with language, some slurred speech, and weakness on the right side. Even in these cases, they won't be eligible for TPA. Go to the next slide. This is just a kind of a quick picture. showing the stroke in an autopsy model. And then this is a very good picture showing how a stroke would damage one part of the brain. Right now, as we all know, in all the countries in the world, the TPA decision is based on just getting a plain head CT. So if a plain head CT looks fine, there's no bleed, like on this picture you can see there's a bleed. Obviously this patient will not get TPA. In this patient you're seeing some, but if the hyperdensity is less than 1/3 of this whole territory, then you should go ahead and give TPA. This is just an MRI and an SWI. Typically not something that we need in the acute setting when the TPA decision is being made, but we'll talk more about it a little bit later. Now, ideally, in all the developed countries, the goal is to give TPA within 25 minutes of getting the head CT, but a lot of times this is not achieved in many centers. This is just some of the epidemiological pattern of how stroke presents. 85% of the strokes are the ischemic type, where they can have a small symptom that resolves completely within a few minutes, or a permanent deficit. A minority of the patients, about 15% of the patients, end up having bleeding, so they can come in with pretty similar symptoms like weakness on one side and stuff, but when you do a head CT you find a hemorrhage, and that hemorrhage can be an intracerebral hemorrhage, which is more common, or in minority of the cases subarachnoid hemorrhage, bleeding in the subarachnoid area. Now the ischemic stroke types, these pictures are showing how the epidemiology is within the United States. Here, there are quite a few cases with atherosclerotic disease in the large vessels, unlike in Asia, where a lot of us end up having atherosclerotic process and having lacunes and having intracranial stenosis. Cardioembolism is another cause that's more common in the Western world compared to the Asian side. One of the reasons is the older we get, the more chances that the heart will misbehave and cause atrial fibrillation. In our part of the world, in third world countries, most of the people, don't grow older than 78, 79 years. While in U.S., a lot of people live in their 80s. So that's why we see more cardioembolism in the Western world. Now, before I go forward and talk a little bit more about the MRIs and why they are important, and I would like to quickly play this video for you to just to show you what this new advancement that I'm really excited about, the interventional aspect of stroke neurology is. I know it's happening in Saudi Arabia and in Pakistan and in Islamabad in at Aga Khan University, but it's not really prevalent, and a lot of people still know from what I've discussed. People in the healthcare world obviously know about it, but this is just one of the pictures I'm showing you. This is something that we do pretty much every day at Cleveland Clinic. At least 1 or 2 patients get it every day or every other day in our hospital. So what they're showing is that somebody comes in with a big stroke. Studies have shown that about 40%, up to 40% of the patients with stroke can have a large vessel occlusion, which means one of the major vessels of supplying the brain can get involved. By these major vessels, we mean internal carotid artery, middle cerebral artery, or proximal parts of the divisions that come out of the middle cerebral artery. The M1 divides into M2s, superior division and the inferior division. So if the clot is in either of these vessels, ICA, internal carotid artery, middle cerebral artery, or superior or the inferior division, the proximal aspects of these divisions, then the interventionalist can go in and pull these clots out. So this picture shows that the patient came in with a stroke. He's in the angio suite. The interventionalist gets an access through the femoral artery in the groin, mostly on the right side, and then advances the catheter into the bifurcation area, injects the dye, looks at the blood vessels. It shows that there's a clot in one of these vessels, the ones that I talked about, and then this happens. So this is the microvire that's going up. It's actually the microcatheter, I think. Microvire. And then this is the microcatheter that goes on. This is the clot that we are seeing. And then just distal to the clot, this catheter is left. And through this catheter, this device, which is normally called a solitaire device, is put in. The catheter is pulled out, and then you leave this stent there for a few minutes, and then you pull the stent out. So what's happening is that this is the clot. I'm showing you the video again. These are called stent retrievers. So these stents kind of go and mesh themselves up into these clots. We give them a few minutes, and as you see this balloon thing occluding these vessels, so that during the pulling of this microvire or of the stent retriever, this blood that's rushing into these blood vessels should not let this clot that's kind of stuck up in this stent should not get dislodged. That's why this balloon is here. And since we leave the stent for a few minutes, kind of gets stuck in that clot, and then there's a suction that's going on consistently. So this is the exciting video that kind of has changed the way stroke is dealt with. It's been around for about 10 years now, but just less than 2 years ago, multiple trials came out, and they showed that these are successful procedures, and patients are now walking out of the hospitals instead of going in with a disability. All right, let's resume where we were again, because this is where this MRI becomes important. Now, this term diffusion-weighted imaging is termed as DWI. What it is in an MRI, we get a sequence that kind of shows the stroke lesion, the ischemic lesion, the infarct, acute infarct as bright white. It's called the diffusion restriction, as you see it here. Now, when these large vessel occlusion stroke patients come in, the majority of the centers do a quick head CT. And if the head CT shows a very small infarct volume or no infarct volume, then most of these centers, if the patient has within 3 hours or within 4.5 hours, depending on the contraindications, they get TPA, and then they get shipped to the OR. So they go to the OR, and then this procedure is done, the video of which you just saw. Now, some of the bigger centers, including our center here, Cleveland Clinic, and a lot of patients at Harvard as well do the same thing. When they come in, they get TPA'd, and then the patients are taken for MRI. Now, the benefit of MRI over head CT is that MRIs are very, very sensitive. So even on a patient, if you do a head CT and it looked very normal, if within 10 minutes you do an MRI, there's a very high likelihood that you'll see some areas of infarct already on the MRI that were not visible on the head CT. So that's where it becomes important, because if a patient comes in and the head CT looks normal and you acutely do an MRI, depending on your facility of how much MRI machines you have and how much funding you have available to get the access you have for MRI, you get the MRI and you see that this patient already has a pretty significant sized infarct, and the patient's exam, clinical exam, is explained by this infarct size. If that's the case, then you look at the blood vessels and you see that there's a clot that is only occluding the vessel that supplies exactly this part of the brain. So in these cases, it doesn't make sense why you would go in and pull that clot out, because the vessel where this clot is in is already supplying the part of the brain that's dead. So in these cases, if you go in and pull the clot out, like the way that I just showed the video for, then this can be a little bit more dangerous, because if you pull the clot out, you're opening the dam up, and this blood vessel will start perfusing this area, and you might see some hemorrhagic transformation. So that's why this diffusion-weighted imaging becomes important, and that's where more and more research is being done to incorporate these imaging sequences in our decision making. Right now, most of these studies that were done, including the SCAPE trial, they had 6 to 8 hours from last known normal. So if a patient comes in within 8 hours of last known normal with a pretty significant deficit, and you do a head CT, which looks normal, and then you do a CT angiogram of the head and neck, a quick test that you can look at the blood vessels of the carotids and the intracranial vessels, and you see a large vessel occlusion, then you can do this MRI and decide whether these patients need to go for the angiosuture. So if they come in within 6 to 8 hours, a lot of the centers just do the head CT. If it looks clean, they take them to the OR. A lot of hospitals do CT aspect, which is calculating the deficit score by looking at the head CT. And some centers do a CT perfusion scan. A few centers, as I said, Cleveland Clinic and Harvard does the MRI as well, because we have the facilities available where we can do that. But if the patient comes in, suppose after 12 hours or after 14 hours of last known normal, in those cases, it's very important that those patients definitely get this MRI done so that we know what the infarct volume is. The reason is that if we don't do MRIs in those cases where the timeline is more than 12 hours, it's very much possible that a head CT looks normal, and if you end up doing an MRI, it will show a bright lesion just like this. And if you open the vessel up, it's possible that you're going to cause more harm than benefit. So just to tell you, this MRI, DWI, the diffusion-weighted imaging, is so sensitive. It's 100% sensitive. It's the best test we have to pick up acute strokes, strokes in the acute setting. You can compare it to the CT scan. The sensitivity is 45%, which is not remarkable. All right, moving forward. So, again, this is a slide that kind of summarizes, especially for internal medicine trainees or senior medical students who are attending clinics in ERs. If patients are presenting with unilateral symptoms, if they're right-handed and they have right-sided weakness, along with that right-sided weakness, they have some language deficits. These kind of things are pretty like an ABC for stroke physicians. These are the things that you look for. And then you look for their vision deficits. Do they have visual loss on one side? Do they have numbness, tingling, facial droop on one side compared to the other? Now, the complexities in the strokes come in the posterior circulation strokes, where they can present with varied symptoms. They can come in with locked-in syndrome, where they cannot do anything other than just do some eye movements. They can come in with fluctuating symptoms, like they're alert, and after 10 minutes they're very sleepy, and then they'll wake up again and they'll move their extremities, and a couple of minutes later they'll be paralyzed in all 4 extremities, and then 5 minutes later they'll move again. So those are very challenging, and it's a totally different ball game. I don't think I'm going to go and delve into that in today's lecture. Now, one of the things that our internist or ER physicians have a lot of difficulty in is that when patients present to the ER and they do not have any weakness on any side of the body, they don't have any numbness, they don't have any tingling, but they're totally confused. It's very difficult for them to say whether these patients are confused or whether these patients are going through aphasia, some language deficits. Now, as I said, most of the patients, if they have language deficits, they should have some weakness on one side of the body as well. However, there are many cases, in some cases up to like 20% of the times, when a patient will come in with isolated aphasia without right-sided weakness. Those are difficult cases, but in my experience and in a lot of different stroke neurologists' opinion, those patients who are confused will not be really making eye contact with you. When you see them in the ER and when you interact with them, they'll be moving all over the place, they'll be looking all around. But the patients who are aphasic, you'll see that most of the time, if not all, they'll be looking at you and they will not be able to follow your commands. They will not be able to read, name anything. So that's one of the most important things that I can pass on in this lecture to help you in making those decisions. Now, suppose a patient with confusion comes in and they were last known normal within 6 hours. Then it becomes important, even if you're having difficulty in finding out whether their sodium is altered, whether they have a urine infection, whether their thyroid is messed up, or it's a stroke, then it's a good idea to quickly get a CT and a CT angio head and neck in these cases to rule out a large vessel occlusion, because a stroke can be treated in that acute phase. Now, if these patients are presenting after 12 hours, like 10, 12, 18 hours out with isolated confusion, then getting CT, especially in third world countries, especially in countries where the resources are limited, then you can wait and rule out other things for confusion before pursuing these stroke-like etiologies. The next commonly encountered thing is the loss of consciousness. If a patient comes into the clinic, last known normal, to the ER, 4 hours ago, last known normal, and then they're here, then and you cannot get a good exam, then I would suggest to go ahead and get a CT angio in those cases to rule out a bleed and then to see if they have large vessel occlusion. Now, there are a lot of centers, most of the hospitals in our countries, in the third world countries, do not have interventional facilities available or even TPA available. So in those cases, obviously, all this is useless. And the reason why I'm kind of giving this lecture today is to discuss and to kind of start this discussion amongst all our physicians, whoever is listening, about what you think, about what the needs are, about what you think we can do to make things better here and there. But if a patient comes in with loss of consciousness within 12 hours of last known normal, then I think it's important to get CT and CT angio head and neck in those patients in the acute setting if you have stroke treatment available. Other than that, most of the time, the typical stroke patient will not present with loss of consciousness. So it's a seizure, or it's altered mentation from encephalopathy or from other things that can cause loss of consciousness. A lot of times patients with syncope from cardiac issues can have that too. I already discussed this, the hyperacute, which means patients presenting within 6 hours for sure, who are definitely interventional candidates with pretty significant deficits and significant weaknesses. These are the imagings that are done in different hospitals before making the decision on what to do. CT scan, non-contrast CT scan is the only thing you need for TPAs, as long as those patients are within 4.5 hours of last known normal. If they're older and they have history of prior strokes and diabetes, then less than 3 hours of last known normal. But for interventional candidates where you are considering that they have a large vessel occlusion, then CT angio, CT perfusion, or MRI if you have that available are the things you need before making the decision. Now, going to a little bit of a complex side, I don't know the exact grade, the exact level of expertise of the people attending this lecture, but this is beyond the medical students level for sure, is the Penumbra concept. This concept is very important, and this is something that we do every day on our stroke patients. Typically we see about 6 to 10 new stroke patients every day in our clinic at Cleveland Clinic, and most of the times at least one of our patients, if not more, comes in with some deficits. And those deficits are for us concerning that they are having a large vessel occlusion. And we can predict that because those patients will have gaze deviation, their eyes will be moved to one side, they'll have language deficits, they'll have very significant weakness on one side of the body. They might have neglect if they're having a right-sided stroke causing left-sided weakness and neglect and extinction of the left side. They can have hemianopia, where they cannot see things moving on the right side or the left side depending on where the stroke is. If they're having these type of symptoms, then that kind of suggests that they're having some cortical involvement. And whenever somebody is having a cortical involvement, then this is a sign, this is a very serious concern that they might be having a large vessel occlusion. By large vessel, again, I mean internal carotid artery, M1, middle cerebral artery, and division, superior or inferior division of the middle cerebral artery. Now, in posterior circulation, the vertebral arteries merge to form the basilar artery, and that's what we call the large vessel occlusion. If there's a clot in the basilar artery or an acute clot in the vertebrovascular junction or one of the vertebral arteries, those are the vessels that people can go in and kind of pull the clot out. Now, going back to the Penumbra concept, somebody comes in with pretty significant deficits. You know, their NIH stroke scale is really high, like in the 20s, and they can't speak, they can't talk, their eyes are moved towards the left side, they cannot move their right side, and we do a CAT scan. And the CAT scan shows a very, very small darkening or hypodensity in the deep part of the brain on the left side. So all of us are clear that that little deep lesion doesn't explain the significant deficits, right? So that patient ends up getting a perfusion scan, whether an MR perfusion or a CT perfusion. And when we do the perfusion scan, we see that there's just that little area that was seen on the head CT, and then around it, there's an area that's kind of turning red, which means that that's the area where the tissue is not dead, but it's at stake. It's going to die if you don't do anything. And then we do a CT angio head and neck, and we find a clot in one of those major vessels that I talked about. And these are the cases that are ideal cases for interventional thrombectomy. Now, the YouTube video that I just showed you is the video for mechanical thrombectomy. That's the term that we use for patients who end up going to the OR and their clot is removed. So it's called mechanical thrombectomy. TPA is, as you know, a chemical thrombectomy. So this Penumbra concept is, in our easy terms, is a tissue at risk concept. So this is the tissue that was already dead, already showed up on the head CT, but this is the area that the head CT or MRI was not showing. But when we did the perfusion scan, that scan showed that there's an area that's turning red, which means this is an area which is going to die if you don't do anything. And this is where imaging becomes so important in patients who are coming in acutely after having a stroke. Now, from the Penumbra concept comes the mismatch hypothesis. And this is the same thing. I mean, what it's doing here is that you're seeing that there's a perfusion scan on the right side, and there are different things, MTT, median transit time, cerebral blood flow, CBV, the cerebral blood volume. And we look at all these imaging, and then we try to see, we kind of decide whether this patient is an intervention candidate or not. What we're seeing is that we're seeing at the core infarct, which is already dead on the head CT or MRI, and then we are looking at the perfusion scan. And on the perfusion, let me move this a little bit away so you can see the image better. So if you see there are infarcts in this patient, and on the perfusion scan, we are trying to look at the asymmetry. Now, on different scans, there are different colors. Like, for example, most of the scans show red color as the area which is at risk. And if there's a small infarct here, and then there's a large infarct area that's not infarcted, but it's showing mismatch, which means on the other side, it's the normal color, but on this side, the color is turning into red. Those are the patients who are great candidates for interventional cases or mechanical thrombectomy. It's kind of the same thing that's shown on this. It's kind of the same hypothesis And I'm kind of mentioning that because in this new era of acute stroke care, this imaging forms the backbone of interventional thrombectomy, of mechanical thrombectomy. What we are hoping for that as time goes up, like right now, our emergency room physicians know that if a patient comes in with very severe stroke, as long as they are within 18 hours from last known normal, they will call this as an acute stroke and will run down, do these acute imaging, look at these sequences, and make a decision whether this patient needs to go in to the OR or not. Now, if this patient is 18 hours out of the last known normal, then there's a huge chance that we will see a big core infarct already on the imaging sequence. So the earlier they come, the smaller the chances of these the smaller the core infarct will be. And if the deficits are large, we assume the penumbra will be huge. Going back to that other case, the case that I started with, that patient came in with right hemiparesis and muteness with, as you know, this side is their left hemisphere, looks fine. And then that patient ended up getting a CT perfusion, and you're seeing that, you know, it's the more scans you look, the better. But here, they show that this blue side is a dangerous side. Most of the scans, you know, it's something that the radiologist can change. But in this scan, the mismatch is that on this side, this area is not perfusing as well as this side. So there's a mismatch. There's a penumbra. The infarct volume is this black thing. This is the core infarct. And the rest of this area, which should have turned red with the bloody color, is not turning red on this sequence. This patient's exam, remember NIH was 18. He will be permanently disabled for the rest of his life. So this patient ended up going to the OR. Now, I won't go into detail about TPA because most of us already know about it. There's a 6% chance of having intracranial hemorrhage. So if anybody comes in within 3 hours of onset, you give them a dose of 0.9 milligram per kg up to a maximum dose of 90 milligrams with 10% as IV bolus in 1 minute and the remaining 90% in 1 hour. And we tell the patients that there's a 6% chance of having an intracranial hemorrhage, 12% chance of having any type of bleeding. The more severe the stroke, the longer the time difference from last known normal, the higher the chance of bleeding is. In interventional cases, the risk is anywhere between 6 to 12% in different centers. In our center, it's about 4 to 6% per procedure. And these risks include everything from a hematoma in the right groin where we go in, from infections, more strokes because we might dislodge clots that are hanging in different aortic vessels and stuff, or causing a bleed. Now that's an important thing that a lot of physicians who are taking care of stroke patients need to know. The modified Rankin scale is one of the universally used things right now. What it does, it simplifies what the patient was doing before they came in. 0, they were independent, 100% functional. 6 is dead. So all the studies that we did here in US and Australia and in New Zealand and Switzerland where these trials were done in the last few years, they included the patients with a modified Rankin scale of less than 3. Because if the patient is already on a wheelchair and they cannot walk without assistance of other people, they're already needing help with activities of daily living at home, then it doesn't really make sense why we would do a procedure which involves thousands of dollars on that. So that's most of the pertinent stuff. I'll just take 5 more minutes and tell you a little bit about, so this is the angiogram of the same patient we just showed you that we discussed the case about. So when we did the angiogram, we saw that on this left side, there's an M1 cutoff. So on the other side, you see the vessels here. So with this exam, with that head CT, with this type of an angiogram, this patient ended up getting a thrombectomy done. And this is this post-thrombectomy imaging. You see the diagnostic angiogram show the vessels are now opening up. And you see it's not as clean, it's slow, but it's getting better. And an ideal procedure is that all the vessels will look just like on the other side. And that's what happened in most of the cases. This was the Mercy Retriever device. This is the first device that came out in early 2000s. And this device did not really succeed in the first phases. And that's why the initial trials kept on failing. And then these Trevo and the Solitaire devices that had the stent in, that I just showed you the video for, when these devices came out, they had changed the world for our stroke patients, especially those who present acutely. The videos I just showed you, it kind of summarizes the same thing. I'm going to pass this on. This is mostly for neurologists who are already certified neurologists. But just to give you an idea on this, these are all the trials that were done in different centers. Escape, Extend-I, and the Swift Prime were the ones that really changed everything. And if you see the odds ratio, there's a benefit favoring the interventional candidates. Twice as better, 4 times as better, 1.7 times as better, twice as better compared to regular patients who just got TPA or who did not get TPA. So this is kind of a revolution in the stroke care. We were lingering around patients who were coming in and going to rehab, never been able to recover. These patients really did well. One of the early concerns were how many times were these patients bleeding, but if you see, there's a little bit of an increased risk of bleeding, but these are not significant. These are all not significant compared to the TPA groups. Same goes with mortality. These were all non-significant. And if anything, it was favoring the interventional arm. So I'm going to go quickly so that we discuss, that I give you some time for questions. So NIHSS for this case at 24 hours was 3 from 18, remember. At 72 hours, it was 1, and with some language deficits. And this patient was discharged home with outpatient physical, occupational, and speech therapy. So these are the slides that I made them up because if anybody has any questions that delves into more details, I can bring those up. Just 2 more minutes. The recent thing that we're doing in acute stroke care is the telemedicine, and that's something that I'm really interested in expanding in other countries as well. So a lot of hospitals don't have neurologists, so if we just have a simple computer and a Skype, or even an iPhone or any phone with a Skype in it, the neurologist can examine the patients and do some quick testing. We can provide you with some basic paperwork that you'll have to help us with in examining these patients, and we'll be able to make a decision whether these patients need TPA or not within 4.5 hours, especially if you don't have a neurologist and if you don't feel confident when to give TPA or not. And in patients who have come in within 6 hours, we can quickly assess these patients through these monitors and let you know to transfer these patients to other major hospitals like King Fahd, King Faisal, Aga Khan, where interventional facilities are available, and those patients can benefit by going there and getting transferred. So this is the tele-stroke model. The recent thing is the mobile stroke unit, and this mobile stroke unit is a device with a CAT scanner and the TPA available. What we're doing here, that this mobile stroke unit is driven around in the city of Cleveland here, and if somebody has stroke-like symptoms, they call 911. This truck goes to their place. The patient is shipped in. They get a head CT. We have a telemedicine in there. We sit on a computer in our hospital. We look at the patient. We examine the patient with our techs and nurses, and we decide whether this patient needs a TPA. The patient ends up getting TPA most of the time, if not all, and then we decide if this patient needs a large vessel treatment or not. If this patient needs intervention or mechanical thrombectomy, then this truck will take them into one of the 3 major hospitals that are available in this Cleveland city. If not, then they can go to the nearest smaller hospital, and they can just get admitted there, and they can do the other workup, like get an MRI or CT scan in 24 hours and go from there. So that kind of saves a lot of resources for the city. And then this mobile stroke unit is being done in Texas and in Germany, multiple centers. It started in Germany actually, and then it came here. And this kind of shows of how quickly we were able to get TPA in most of our patients through this telemedicine, through the use of the mobile stroke unit. So I'll stop here and I'll give you time to see if anybody has any questions. And I would be interested in hearing from you as well. These are my email. If anybody wants to ask, inquire, collaborate, discuss, share your expertise of what your things are. I would also be interested in seeing if you have a stroke database